Hey guys, this is Dr. Watt from Pinecrest Chiropractic. Let's talk about the dumbest joint in the body, the knee. I would say the knee is the dumbest joint in the body because all it does is it compensates for the hip and the ankle. That doesn't mean it's not pretty cool though, and there's not a lot of things that can go wrong with it. So let's talk about that. When we have a patient come in with knee pain specifically, we're going to look at, yes, the knee, but we also need to look at those joints above and below. We need to examine the ankle, see if there's previous traumas or issues there, check its range of motion and stability. We then need to go up and look at the hip as well, check its range of motion or lack thereof, as well as the stability within the hip as well. And finally, we need to look at the low back, because if there's something off with the low back, that can create issues all the way down that kinetic chain. And so yes, the knee is a dumb joint, but having issues there is going to affect above and below. So we need to figure out, is the knee pain causing issues elsewhere, or are there issues elsewhere that's then causing the knee to compensate and creating issues there? So that's the first thing we need to do when we do an exam on you to come in for this, figuring out where this is coming from. Then when we zoom in on the knee and figure out that you do have a knee issue, we can put it into two general buckets. We can put it into more of an acute issue, which is what many of us think about with knee issues from athletes. So we look at our ACL, PCL, LCL, MCL. Those four ligaments are all responsible for creating stability within the knee between primarily the tibia and the femur. A little bit of fibula out there as well though. But that stability is crucial for you being able to move and cut and change directions. Once we see all four of those ligaments are fine, we also want to look at the meniscus. The meniscus is what sits in between the tibia and the femur, and that's going to help make sure that it glides appropriately. This is where people will report things like clicking or grinding or locking, where that knee feels like it's locked in a specific position. So we'll look through all those ligaments as the meniscus as well, and those are our primary acute type injuries that patients oftentimes worry about. Then when we look at more of a chronic type issue, we're going to look for things like degenerative knee issues, we're going to look for things like osteoarthritis, or even some of those old injuries that have now compounded. Once we check and clear all of those things, we now know what bucket to put that patient in. We'll do things like checking your range of motion, both flexion and extension, because it is a hidden hinge joint, but it does also turn a little bit as well. So that's a tibial rotation that we're going to measure as well. We'll measure some strength and stability with some of the surrounding musculature, making sure that it's the proper amount of stability that you have based off of your height and body weight and what you're asking your knees to do. Once we have a full exam, we now need to start treating. And so how do we treat knee issues? Well, we've got a lot of tools in our tool belt. We can start with some of the modalities that we have, things like using infrared laser, which are going to help those tissues heal up, either expediting that healing process or starting that healing process again on something that's chronic and hasn't been healing well in years. We can do things like Shockwave, which are going to break down those tight muscles and start that healing process up again. So breaking that tissue down to a base level so it can then start to have a better foundation to build off of. We can do dry needling to really attack those trigger points and knots, oftentimes in the quads or the hamstrings, that are pulling and causing tracking issues as well. We're going to adjust that. And then my favorite modality is going to be the knee decompression device. We have a knee on track, which is, like I said earlier, a knee decompression. So it's going to take those knees that are no joint space in between, that they've been told is bone on bone, and they've been told, hey, it's time for you to go get knee surgery, possibly even replacement. But when we start to traction that apart, we're increasing that joint space, allowing more blood to flow into that area. Now, very often we use a culmination of these different treatments in each treatment plan to attack every piece of the puzzle that's affecting and creating your knee issues. If you have any more questions, come on in. Let's chat about it.